into the virtual room. So I'd like to begin by acknowledging land. We are here in Victoria. I'm on Wurundjeri land of the Great Kulin Nation. I'd like to acknowledge elders past and present, Aboriginal people with us today, emerging Aboriginal leadership, and acknowledge that this is and will always be Aboriginal land. And it'd be really terrific for those of you with us today to pop in the chat which lands you are from across this great country, because we have people from every single state and territory here with us today, from both our sectors, but also from respective state and territory governments. Welcome to today's webinar delivered under the TriPeaks project, a collaboration between the Centre for Excellence in Child and Family Welfare, the Victorian Healthcare Association and the Victorian Alcohol and Drug Association, or VADA, to support integrated practice and good governance across our three sectors. On behalf of the TriPeaks, that is Sam Biondo and Nick from the Victorian Health Association, I would also like to acknowledge colleagues from the Department of Families, Fairness and Housing and the Department of Health and other service providers. We have almost 500 registrations from across Australia. And on that note, I'd like to also welcome all of you from every state and territory to the session today. I'm sure you're going to find it a really interesting session. Today's webinar is the next webinar in the TriPeaks Innovation webinar series, focused on cross-sectoral solutions relevant to child and family, alcohol and other drugs, and community health services sector. The webinar series will provide a platform for the three sector workforces to collectively hear about innovations and intersections across the three sectors. In today's webinar, Professor Ben Mathews and Professor Daryl Higgins will provide an update on the progress of the Australian Child Maltreatment Study. You will recognise Ben and Daryl from the TriPeaks webinar they presented in 2020, or more recently from the Australian Institute of Family Studies, or ACE conference. Across child and family services, alcohol and other drugs, health, and within government, we know there is a strong desire to use evidence-informed models to inform policy, practice and service changes that are needed to best protect Australian children. The Australian Child Maltreatment Study echoes that sentiment strongly, but on a national level. It is great to see the shift towards embedding evidence into policy and practice, but that momentum must be maintained as we head towards the various state elections here in this country. This study is so critically important in obtaining the first-time accurate baseline data about the number of Australians who have experienced child abuse and neglect. This is an exciting opportunity for policymakers right across Australia, with the study providing critical insights about which children are most at risk, where they are and who they are. This information will significantly strengthen our ability to develop effective policy and prevention initiatives and early intervention opportunities. So we're not going to hear all about this study today, because this is a sneak peek. Much of the release of this research will be next year, but hopefully we get to hear a little bit more about it today from our colleagues, Ben and Daryl. So today's webinar will be recorded and the slides will also be distributed. During question time, please feel free to use the chat and QA functions located in the bottom toolbar. And as time allows, we'll try best to respond to questions and comments. And Ben and Daryl have agreed that if we don't get to questions, they're happy to take those questions offline if we email them. We're very grateful to have both of you here today. And now I'm just going to introduce you both quickly. So Ben Mathews is the lead investigator of the Australian Child Maltreatment Study. He is a professor and principal research fellow in the School of Law at Queensland University of Technology, and is an adjunct professor at Johns Hopkins University, Bloomberg School of Public Health. He was a professorial fellow to the Australian Royal Commission into institutional responses to child sexual abuse, and has served on 2 World Health Organization guideline development groups on health sector responses to child maltreatment. His research focuses on how social health and legal systems can best prevent, detect and respond to child maltreatment within a framework of public health, law and children's rights. Professor Daryl Higgins is with the Australian Catholic University. He commenced as the Director of the Institute of Child Protection Studies in February 2017. Daryl's research focuses on public health approaches to protecting children and child-safe organisational strategies. A registered psychologist, Professor Higgins has been researching child abuse impacts and prevention, family violence, and family functioning for 25 years. Professor Higgins is one of the chief investigators in this study. These are two great humans. I love working with them. I'm going to hand over to Ben, I think, who's going to take us forward. So over to you. Thank you.
Deb, thank you so much for that lovely, warm and generous introduction. And to everyone, it's wonderful to be with you today. Thank you. Indeed, thanks to Sue, Pauline, Danielle, Ollie, everyone at the Centre and at TriPeaks for your support for us and our study from its initiation. In fact, we gave probably the first big launch of our study in Melbourne, hosted by you in August 2019. That feels in some senses like a lifetime ago. In another way, feels like almost yesterday. So we are really thrilled to have your support. One of the things that's really important for us in this study has been to conduct gold standard science, but equally important has been to engage with government agencies and non-government agencies and peak sector bodies such as yourselves, because we want our findings to go to the people and organisations that can best use them. So we want our findings to inform future public health prevention and improved policy and practice to best support children, parents, families and communities across Australia. So thank you all for engaging today. And we look forward to engaging with you again in person in Melbourne in March. The date is to be determined, but it will be in March in 2023, where we will share all of our main findings. Currently, the main findings are under embargo, but today we can, in fact, give you a sneak peek at some selected findings. And there are some sobering findings there, but we're sure that you will see just how salient these findings are in terms of generating an evidence base that can be used to inform enhanced public health prevention in future. So there'll be an awful lot happening around March. Our main findings are currently under review with a leading journal, and we anticipate they will all be published as a package of 7 articles in a special edition of that journal late February, early March next year, and they will all be available on an open access basis to the world at large. So they will be made available to all of you. So we're really thrilled to be with you today. Thank you. And without further ado, we will just talk today about basically why we needed this study, what we've done, how we did it, and give some examples of what we found and the implications of those findings. I'd like to acknowledge the First Nations owners of the lands where we all meet and pay respect to their elders, laws, customs and creation spirits, and recognise that these lands have always been places of teaching, research and learning. And I'm coming to you from the lands of the Turrbal and Yagara peoples. Folks, we are dealing with some sobering and sensitive topics today. If anyone does need support after listening to today's presentation, please do reach out to get that support should you need it. This presentation, as with all of the presentations we give, are given on behalf of our whole team. So this has been a massive study. We're nearing the end of the 4th year of this 5-year study. We've had 10 chief investigators and further support personnel, including our project manager, Dr. Deebna Haslam, statistician, Dr. Eva Malakova. Our 10 chief investigators are mostly from Australia, but there's a few names that you might recognise there from overseas, including David Finkelhor, who's probably the world leader in this field. He's conducted 4 national studies of child maltreatment in America, and he's been an absolute joy to work with and incredibly generous with his time and expertise. Just like to acknowledge our funders, the NH&MRC that funded this study, but also of note, the Australian government has given strong support for this study from the outset. So the Department of Social Services in particular contributed some extra funding to support the inclusion of questions about some really important topics in this survey, including about institutional child sexual abuse, online, internet, sexual victimisation, and disclosure of sexual abuse. So we will be sharing these slides with you. This is just an overview of what we'll be talking about today. So why did we need this study in the first place? Why have we invested the last 4 years and even more time before that? Because there's an awful lot of preparatory work that we engaged in even before applying for funding for this study. In essence, the reason why we've done this study is that until now, as a nation, we have not had reliable evidence at the population level about 3 really important things that need to guide our practice. One, we haven't known the true prevalence or the true proportion of the population who experience each of the 5 main types of child maltreatment. So we haven't had really strong, reliable evidence about what percentage of kids through the span of childhood up to age 18 experience physical abuse, sexual abuse, emotional abuse, neglect, or exposure to domestic violence. And that is a massive gap in our knowledge. That's a huge gaping hole in the evidence. And we need that evidence base to help inform policy and practice, and where we triage our efforts in terms of a whole host of sectors, many of which are represented by your presence today. So we need that prevalence data about what proportion of the population experience any maltreatment, each individual type of maltreatment, and indeed multi-type maltreatment. So the kids who experience more than one type of maltreatment. But the second thing we also need is connected with that. So we do need the prevalence data, but that actually is not enough to inform us about where we most need to act. So we need more. We need nuanced data about the characteristics of each type of abuse and neglect. So there's a few examples of the types of data that we've generated here to fill these evidence gaps. So, for example, how old are children when these different types of maltreatment normally commence and then end? What are trends by sex and gender? So are females, for example, more likely to experience some of these types of abuse than males? Are gender diverse kids more likely to experience maltreatment types? A third dot point there is also really important. So which types of maltreatment occur most often? Which subtypes within those types of maltreatment occur most often? And which types are most harmful for mental health and health risk behaviours? That domain of this study is very, very important for policy and practice. And the fourth dot point is also really important for prevention approaches and directing efforts and investment. So who is it who inflicts different types of maltreatment? And that applies in particular to physical abuse, sexual abuse, and emotional abuse, not so much to neglect and EDV. And the third domain there is that we lack reliable evidence at the population level about the associated mental health disorders, health risk behaviours, and physical health conditions that are consequent on child maltreatment and specific types of maltreatment. So as you can see, there's some massive gaps in evidence that have really impeded informed public health approaches. So what we've tried to do in this study, essentially, if we think of it in conceptual terms, is to advance our efforts in precision public health. Basically, we've taken on the challenge of generating this evidence, which is essential to inform better targeted approaches to prevent child abuse and neglect in the first place, to reduce its associated health and risk behavioural outcomes when it has happened, and to reduce economic cost to the nation that it causes. And obviously these findings are significant, not just for one sector. They are obviously important for child protection agencies and practitioners, but they're relevant across multiple sectors and government portfolios that serve children, families, and communities at large. So they are significant for early childhood education and care, education sectors right through the span of primary and secondary, child protection, family welfare, and out-of-home care. They're also relevant for broader health and justice systems as well. Okay, so what have we done? In a nutshell, we've generated this new national evidence, hopefully to inform policy and practice moving forward. It's the first comprehensive nationwide study of the prevalence of each form of child maltreatment and multi-type maltreatment, also of the characteristics of those experiences, as I just mentioned. We've measured key health and risk behaviour outcomes of these types of child maltreatment through the lifespan, and we'll also be measuring the burden of disease from maltreatment. We've also measured health use outcomes associated with child maltreatment. How we did it, we did a lot of preparatory work before we even sought research funding from the NHMRC. So one example of that was a Royal Commission funded scoping study that Daryl and I were heavily involved in how best to do one of these studies. But we also did a separate systematic global review and critical analysis of all studies like this done elsewhere in the world to find the best methodology. So our study and our method was informed by that. And basically what we've done is a nationwide cross-sectional survey. We carried out the field work last year. So it took 6 months of field work from April to October in 2021. And we administered our survey instrument through computer-assisted telephone interviews. So we trained about 80 interviewers through our partner, the Social Research Centre in Melbourne, and they administered our survey instrument to 8,500 Australians, and they plugged in all of those fantastic participants' responses into our software platforms. So we generated a random sample of the population, 8,500. Everyone was aged at least 16. We actually had a very strong oversample by design of participants who were aged 16 to 24. So we had 3,500 people in that age group. And the main reason for doing that was to generate particularly strong evidence about their experiences of maltreatment and associated outcomes that are happening now, and maltreatment obviously that's happened in relatively recent times in Australian society. We then had 5,000 adults aged 25 plus, with 1,000 in each of 5 age decade strata from 25 to 34, right through to age 65 plus. And one reason for doing that is to see what the situation has been in terms of prevalence of child maltreatment at different times in Australian society. But even more importantly, perhaps, is to enable measurement of the outcomes of maltreatment right through life, through middle age and even into old age. We generated a random sample that's representative of the national population. So this is not a convenience sample or a clinical study. It's a genuine random sample, extremely rigorous. In a nutshell, we could easily talk about this all day, I'm sure, but in a nutshell, the survey instrument that we designed was an enhanced, adapted version of David Finkelhauer's survey instrument. And so that's its name there, the JVQ R2 Adapted Version Australian Child Maltreatment Study, a bit of a mouthful. In a nutshell, we had about 9 or 10 key components of the survey. So we measured all 5 types of maltreatment. We had sections on mental health, physical health, health risk behaviours, health service use, criminal justice involvement, intimate partner violence, victimisation in adulthood. We also measured peer bullying and sibling violence and other adverse childhood experiences as well, both as experiences that are important in their own right, but also so that when we were conducting our analysis of outcomes of maltreatment, we could take into account those other adversities as potential confounding factors on those outcomes. So a very comprehensive study, but very, very rigorous in all of those domains. If you're interested, the average time the interview took for each participant was about 30 minutes. So I'll just go through a couple of key points about how we measured the 5 types of child maltreatment. This was again informed by that global systematic review and critical analysis of all national studies that have been done before. And we concluded that David Finkel's instrument was the best available survey instrument for many reasons. But we then spent the first 2 years of this 5-year project really breaking even his instrument down and going through a process of enhancement and adaptation and validation so that it met all of the needs of our study. So without labouring the point, we did a lot of conceptual analysis and critical appraisal. We consulted with an international panel. We modified the questions where necessary. We then did cognitive testing with convenience samples, including survivors of maltreatment. We then did a main pilot test and retest. So that process itself was exceptionally rigorous by international standards, took 2 years, and that's what it took to get our survey instrument ready for implementation in the actual survey. As a result of that, what's really important to emphasize is that that process of designing the questions has meant that we have employed gold standard definitions of each of the 5 maltreatment types and gold standard operational examples of each of them in our survey. That means that the data that we've generated is rigorous and reliable. It will neither overestimate child maltreatment in any of these domains nor underestimate it. In any example, in any domain where we could possibly have erred on the side of being too conservative or less conservative, we took the conservative route. So this has been a really rigorous process of survey design, but that's necessary so that our results can be relied on by governments and policymakers and practitioners. I'll just give you an example of how we defined one of our types of maltreatment, and this is summarising the approach to emotional abuse. So we conceptualised emotional abuse based on the literature and the best surveys as parental behaviour, which is typically repeated in a pattern over time, that conveys to the child they are worthless, unloved, unwanted, or only of value in meeting another's needs. And operationally, we integrated that into the survey through 3 questions, which were about 3 domains of emotional abuse. One was about verbal hostility. One was about rejection, so saying they hate the child or don't love them or never wanted them. And the third was about denying emotional responsiveness. So, for example, consistently ignoring the child or not showing love or affection. And when we calculated the prevalence of emotional abuse, we only counted these things as constituting emotional abuse if they happened over a period of at least weeks. Okay, so it could have been over weeks, months, or years. So we did not count things that may have only happened once or over a period of days. Another example is how we assessed exposure to domestic violence. We actually ended up with 4 questions on EDV, which covered physical assaults, threatened physical assaults, sexual violence, but also damage to property or pets and coercive control. So a very, very rigorous, extensive process, and you can see exactly how we did this in our publications, which are linked and available through this presentation. What we ended up with, I'm just conscious of time, so I'll skip over a few slides and then hand over to Daryl shortly. But what we ended up with was measuring child maltreatment through 20 questions. For physical abuse, we had 3 questions. 2 were about different levels of physical abuse, so moderate and then severe. We then had a question on corporal punishment. Now, I'll just note to you that the corporal punishment data are actually fascinating, and Daryl has really led a lot of work on this, and it's captured a lot of public attention, and deservedly so. But I will say that when we generated our prevalence estimate of physical abuse, we only counted the 2 that were on the physical abuse questions. We did not include corporal punishment in them. Sexual abuse, we had a strong focus on in this study. We had 2 questions on internet sexual victimisation that we just asked to the youth sample age 16 to 24. We then had 5 other questions on different manifestations of sexual abuse, from non-contact sexual acts right through to rape. And 4 of those key questions generated our prevalence data on sexual abuse. We then had 3 on emotional abuse, 3 on neglect, and 4 on EDV. Now, each of those questions had a yes or no response. So they're called behaviourally specific questions, which give very, very reliable data. That gives us the prevalence of each of those 5 types of maltreatment. What we then did was, for every one of those questions, when someone said yes, we then asked some follow-up questions to obtain that rich, nuanced information about the characteristics, the context, and the risk factors. So we asked how many times did it happen, or for physical, sexual, and emotional abuse, or for neglect and EDV, over what period did it happen, i.e. days, weeks, months, or years. We asked how old was the person when it began in childhood and ended. We asked for physical, sexual, and emotional abuse, who were all the people who did the acts. And that information gives us really, really rich, valuable information, for example, in sexual abuse, about prevalence of sexual abuse by parents and parent-like caregivers, sexual abuse in institutional settings, sexual abuse by adolescents who the child knew, for example, by boyfriends or by other known male adolescents. So it gives us exceptionally rich data about the nature of offending, or the nature of maltreatment types. We also asked for sexual abuse and physical abuse 4 questions about disclosure. And this again is of such huge relevance for future policy and practice. So we asked people if they had ever told anyone about any of that particular experience. If so, how old they were the first time they disclosed, who they told that first time, and if they felt supported. This little slide just gives you a full global overview of the types of questions we asked to obtain the prevalence data and the characteristics of that. What about the health and behavioural outcomes then? The mental health section of our survey was exceptionally strong in epidemiological terms. And the reason for that is that we didn't just ask people about their own perceived symptoms. We actually used a clinically diagnostic interview, which is called the Mini International Neuropsychiatric Interview. And this gives us diagnostic information for 4 key mental health conditions: depression, anxiety, alcohol use disorder, and post-traumatic stress disorder. So this data, again, is exceptionally robust and reliable. We also measured physical health and adverse risk behaviour outcomes using modules from validated surveys or other tailored items that we validated through the pilot process. I'll just highlight the health risk behaviours that we measured. So we measured smoking, both lifetime and in the prior year. We measured subclinical alcohol use, so binge drinking. We measured cannabis dependence. We measured self-harm, and we measured suicidal thoughts and attempts. As a result of this extensive interview and really robust methodology, we now know an awful lot that we did not know before. So just to give you an example of key findings that we've generated, and these little bubbles don't have the actual figures in them, but I'm going to allude to a couple of things kind of obliquely here for you today, and then Daryl's going to give you some key findings. So we now know at last in Australia what is the prevalence of each of the 5 types of child maltreatment. So we now know the actual percentage of the population that experienced physical abuse, sexual abuse, emotional abuse, neglect, and exposure to domestic violence. And there were a couple of surprises there. I will just mention at this point that this study has generated a lot of sobering and quite chilling statistics. Those statistics are not just data. They obviously represent a huge toll of human suffering. So kids have suffered terribly in this country, and they continue to. So this is a clarion call for us to redouble our efforts, but to target our efforts informed by this type of evidence. So we now know that the true prevalence of each of these 5 types of child maltreatment at the population level. As I said, there are some sobering findings, but there are also some good news stories, and that's really important for us to focus on, because it shows us where our efforts have been making positive gains, and it illuminates perhaps pathways forwards for us where we can make further gains. And there's several of our publications highlight that. So we'll be talking more about that in due course. The second thing we now know is what's the prevalence of multi-type maltreatment. So what proportion of the population experience 2 or more of the 5 types, and what proportion experience 3 to 5 types, and even 4 or 5 types. The third thing we know is how badly are Australian youth suffering right now? What's the situation on the ground right now? And some of those findings are good news stories for some types of maltreatment, others not so good. But again, we need that evidence to inform our efforts in future. The fourth thing we know is the risk for females and males and for gender diverse individuals. And there are some really, really salient findings there. And I think it's fair to say, without giving the game away too much, but we clearly have a problem in this country in terms of the sex disparity that was present, that we found in this study. Females are at substantially higher risk of 3 of these 5 types of maltreatment. We need to do a much better job of taking care of our girls. And we can see this type of trend in so many areas of social experience in this country. We see it prompting things like national plans to better prevent violence against women and children. This is just a call to redouble those efforts, this evidence that we've generated. The fifth thing that we've found is at what age do mental health disorders and risk behaviours occur? And this is really, really important, because we found that where the adverse outcomes of maltreatment happen, they don't just lay dormant until, say, the 40s and 50s in life, they happen early. So this amplifies the damage that child maltreatment causes. Obviously, if mental health problems and risk behaviours are happening in the teen years and the early 20s, then that's affecting performance at school, ability to navigate relationships, ability to get gainful employment. So this is really, really important information. And the sixth thing there is that we now know which maltreatment types have the strongest adverse impact. And that is of crucial importance for sectors such as yours. So our findings have major implications for prevention at all levels, for early intervention, and for trauma-informed responses across these sectors. I'll skip over this in the interest of time, but obviously key questions that we can ask have major implications for policy and practice, both at the broader level of preventing overall types of maltreatment, but also in a much more granular way in some senses as well. And we'll be doing more and more work about these more fine-grained questions that have particular implications for law, policy, and practice. At this point, I'm going to hand over to Daryl, who's going to take you through some selected findings on self-harm.
Great, thank you, Ben. So on the next slide, I'm just going to give a little bit of an overview of one of the key findings that we've already talked about a little bit for those of you who may have been present at the Australian Institute of Family Studies conference on non-suicidal self-injury. So for short, self-harm. So talking about the prevalence that we found of that health outcome or health risk behaviour, and its association with the various forms of child abuse and neglect that we have measured. So the definition of non-suicidal self-injury or self-harm that we're using for this study, how we operationalised it, is the deliberate damaging of one's own body in the absence of any intention to die. So in terms of existing data that we have for comparison is the longitudinal study of Australian children, where just over 30% reported thoughts of self-injury, but 17.8% reported an act of self-injury. So let's have a look at what we found in the ACMS study with our younger sample. So that's our 3,500 16 to 24-year-olds. So the question that we use to operationalise that definition, have you ever deliberately harmed or injured yourself without intending to end your own life? And then, as Ben has already explained, we measured each of these 5 forms of child maltreatment. And we're going to now show you not only the overall prevalence of non-suicidal self-injury, but the pattern of association with each of those forms of child abuse or neglect. Thanks, Ben. So here's our sneak peek. Just over 30%, so 30.5% of the young people in our sample, the 16 to 24-year-olds, reported that they had ever self-harmed. I think you'll agree that that's a very sobering and somewhat shocking finding that just under 1/3 of participants said that they had ever engaged in self-harm behaviour. On the next slide, then we can see the gender breakdown. So it's almost the rate for females compared to males. So very strong gender differences here. Again, very important findings for understanding the way in which we need to think about both prevention and responses when we're thinking of how males and females might present to services that are represented by the TriPeaks webinar here. So I hope that this data is really useful for you. Then on the next slide, you can see the associations with between self-harm and each of the 5 types of child abuse and neglect. So the third column, the unadjusted odds ratio, is the simple association between, so for example, on the top line, sexual abuse and females, there was 5.9, so almost 6 times the risk of self-harm if someone had experienced, if a female had experienced sexual abuse, 3.7 times the odds for males. Then in the final column, this is after having taken into account the potential that they have experienced other forms of maltreatment, so physical, emotional neglect or exposure to domestic and family violence. And so you can see the odds of experiencing self-harm is lower once we take into account that a number of the people who'd experienced sexual abuse had also experienced these other forms of maltreatment. So as Ben has already indicated, there's a lot of overlap between experiences of different forms of child abuse and neglect. So when we look at any one type, it's important to look not just at the simple direct association between that form of abuse or neglect and an outcome such as non-suicidal self-injury. We also need to take into consideration the likelihood that that person may also have experienced another type of harm. So the general pattern here is very strong associations between each of the types of child abuse and neglect individually and the risk of self-harm, but that it reduces once we take into account the association with other forms of abuse and neglect. But really the strongest ones were particularly sexual abuse, physical abuse and emotional abuse, less so with neglect and exposure to domestic and family violence. Thanks, Ben. So we can see here the summary of the results that I've talked through. Almost a third experiencing self-harm across the lifetime. Females almost double the risk. And so we know then that the associations between self-harm and sexual abuse, emotional abuse, and physical abuse were strongest, both for males and females, even after we controlled for the experience of those other forms of child abuse and neglect. Less so for neglect and exposure to domestic and family violence. Thanks, Ben. So the final section that I'm going to be talking about before I hand back to Ben to talk about the release of our results and the next steps is just to make a few reflection points around how these kinds of data, such as the snapshot that we've just shared today, can help with more precise responses from a public health perspective, and how we can try and progress a real culture within Australia of prevention and better services and supports for those who have been harmed. So on the next slide, you can see here some of the key agendas, if you like, and ways in which we see there being opportunities for the results of the ACMS to influence public policy. And thanks for the question that someone posed earlier in the chat function about the idea of practice frameworks. And while we aren't ourselves going to be developing those frameworks, we are going to be engaging with a range of end users, particularly through frameworks such as the National Framework for Protecting Australia's Children, and organisations like the Productivity Commission, who've already said that we need to have a national approach to early intervention and targeted support for children and families. We know that the annual cost of mental ill health and suicide is between $200 and $220 billion. So really have a shadow pandemic of mental disorders in 16 to 24-year-olds. And our results will demonstrate the relationship that those kind of mental health outcomes, such as the suicidal behaviours that we've been talking about today, that's just one example, but our results will be able to demonstrate where those patterns lie and how, therefore, we might be able to drive our both prevention and early intervention efforts, particularly those ones early in life, and the relationship between prevention of child abuse and neglect and prevention of mental health will be really important. And of course, opportunities to support new parents and to support the socio-emotional development of children throughout life, but particularly in school-age children, will be really important. On the next slide then, what we've illustrated here is the importance of, from a public health perspective, which is really about driving change at the whole of population level, the importance of being able to have a tiered approach where we're able to direct the majority of prevention activities at what we call the primary or universal level. So using universal platforms, as Ben said before, like early childhood education settings, schools, health services, etc., that are accessed by most families and get to most of the population. And the idea is that it's primary prevention, i.e. addressing the risk factors that are highlighted by studies such as the ACMS in order to turn around the likelihood that a child is experiencing abuse or neglect, and then have less need for investment in secondary services. So most of the investment, if you like, going into primary services, then have a smaller proportion going into secondary services, which are those targeted to families to alleviate emerging problems and prevent escalation. And then the smallest investment in tertiary responses, so services or interventions for children and families where abuse or neglect has already occurred. Now, of course, if you were to map our current investment, it's probably the reverse, where we have a lot of funding going into statutory child protection services and much less going into secondary and universal or primary level strategies. So we know that in order to kind of get to this ideal approach to prevention, that there's a resource challenge, We know that there are different approaches that are needed according to both the different type of abuse or neglect that we're trying to prevent, but also the different service delivery system in which we might be delivering. We know that there's some great evidence around things like home visiting programs, but of course, take up of that and funding and delivery of those are real challenges. And we know that genuine primary prevention strategies at the whole of population level are really hard to evaluate and share the evidence on. So we know that there's a lot of challenges there. In this final slide, I think it's the final slide from me, Ben, is just some examples drawn from the CDC, so the American Centers for Disease Control and Prevention, that just summarises what are some of the key components of a public health approach to addressing violence against children. And it uses the acronym of THRIVE, so training in parenting, so evidence-based parenting supports, household economic strengthening, reducing violence through legislative protection, improving social and therapeutic services. And of course, many of the participants in today's webinar are in that space. Values and norms that protect children, so changing kind of attitudes, changing community culture. Of course, we've seen how important that is in related areas of public health approaches to prevention, such as in, changes to smoking, changes to road safety, etc. Education and life skills, and then finally surveillance and evaluation. So a study like ours is not the end of the road, it's really just the start of the road of getting data out there so that we can continue to monitor and evaluate the effectiveness of prevention programs. Thanks, Ben.
Daryl, I think there may be just one more, unless I've deleted it by mistake. There we go.
Oh, there we go, finally. Okay, I'll talk to this one. So we're hoping that data such as this will really be able to help us make our public health approach more precise. As Ben has said, a lot of the focus of the ACMS is about exploring characteristics, not just of the individuals who have reported experiencing abuse or neglect during childhood, but also the characteristics of the circumstances in which that abuse occurs. So particularly familial versus institutional, but also many other associated characteristics. And that will help us drive those prevention efforts from a public health approach, as well as the response characteristics. And I think the example of the data that we've shared today around the incredibly high frequency of non-suicidal self-harm behaviours that our participants have reported really, I think, will help drive the more precise targeting of early interventions and health responses, mental health responses based on these kind of data. So you can see some examples of the ways in which data can be used there in terms of understanding the circumstances of children and young people, how best to support their parents and families, the age at which these kind of events are likely to first emerge, but also when they typically emerge, can help drive questions around when to intervene, where our prevention dollars are best spent, and particularly which kind of portfolio and which age group is addressing that target group. Recognising, of course, that there can be effects on other sectors, and therefore helping us drive coordinated policy responses, building practitioner capacity right across the different sectors, particularly those who might not see themselves as being responders to child abuse and neglect, but data such as ours hopefully will help people recognise that they are actually dealing with the consequences of child abuse and neglect. And right across the board, building public awareness and participation in the collective effort of making the next generation of Australia's children safer and growing up in environments free from abuse and neglect. Thanks, Ben. Now it's over to you.
Thanks so much, Daryl. That was terrific and really gave a nice summary there of the public health implications of what we're doing and of some of those quite confronting findings about self-harm. Folks, I'll just very quickly let you know what's happening next in our study. I will say, and someone I think mentioned informing practitioner frameworks, we are engaging quite intensively with many stakeholders in this space across the nation, both at Australian government level, but also at state and territory levels as well. One example of that was yesterday I presented to all state and territory chief practitioners to give them an indication, just as we are today, about what we've done and where that's going to hopefully be able to lead us. And I'll be engaging more with them and similar folks through next year and even beyond next year. So there will be an awful lot of work and engagement and discussion about the significance and implications of our findings for reforms, not just next year, although it will intensify next year, but for the next 2, 3, 5, 7 years. This is a long-term commitment, and this body of evidence that we've generated should have that type of durable effect on informing enhanced policy and practice. We're also engaging with a lot of Australian government agencies as well, both at the government level and non-government. So we presented to the National Mental Health Commission yesterday, for example. So we're doing as much as we can to make sure that the folks and organisations that can really use this data do become aware of it. So right now we have our major findings in 7 articles currently under review. We anticipate they'll be published early March in a special edition on an open access basis, and we'll be having a public launch through several events, including in Brisbane, but also in Melbourne in March 2023. So we'll be letting you all know when those events happen. We've got a bunch of other work happening as well on our next kind of set of key priority articles about the data that we've generated. So those articles will also all be made available to everyone on an open access basis. And then we've planned another set of 7 or 8 papers that we'll be working on through March to December next year as well. So we've done a lot of hard and good work, but we're not letting our foot off the pedal. We'll be going through pretty hard next year, and we will continue to be publishing things that are of high salience for sectors such as yourselves, even after next year. Just a little graphic there about where we've come from, what we've done, what's coming up next. And there's a stack of resources available to you here through our publications and also our website. So feel free to access those should you wish. And please do feel free to reach out to us and sign up to our mailing list if you'd like. Our website has a lot of information about the study, and all of our outcomes will be posted to our website. If you do have any questions that you'd like to run past us, please do feel free to reach out. Deb, I think we are kind of on time. We do have a couple of minutes should there be any questions. And at this point, I might stop the screen share. But thank you again for your attention and engagement today.
Fantastic. Really great presentation, and I just want to commend the work. It's going to help us gear our thinking over the next 5 to 10 years, and really salient data in terms of self-harm, particularly for young women, as Daryl presented. There are a couple of questions that certainly Daryl's been, and you, Ben, have been busily answering them, which is great. But there are a couple of prevailing questions. One really is about disability or cognitive issues, and therefore, have those been factored into the findings, and are those young people at greater risk? We'll stop with that one to see if either of you want to answer that question.
Daryl, I'm happy to take this one. So this was designed as a survey of the general population. So it wasn't designed specifically for individuals with a range of impairments, whether cognitive or other. But what we can say is that all of our participants had sufficient cognition to understand the nature of the questions they were asking. We didn't specifically ask about disability or impairments in this survey. So we frankly don't have that level of information for that subpopulation of Australians. However, I can say that there may well be an appetite at Australian government level to support a subsequent study that may have more attention and more focused questions to generate evidence about the experiences of Australians with both cognitive and other impairments. So we can certainly keep you updated on developments in that space.
That's great, Ben, thank you. And the last question is really about gender. Yolanda's put a great question in there about if gender was identified in the binary, or was the study really, endeavoured to be as inclusive of all genders as possible?
Yeah, I'll answer that if you like, Ben. It's a great question. And we were very lucky that just as we were finalising the instrument development, there'd been a number of advances in this space, particularly by the Australian Bureau of Statistics, in terms of how we should collect data about participants' gender identity and also sexual identity. And so we are very fortunate that we've got some of the most comprehensive data on participant identities, and so we will, as appropriate, be analysing using that. Now, of course, the prevalence of some of the different categories is quite small, and so to be able to break down and give separate outcome data for each of those subcategories is going to be difficult, but certainly a broad category such as all of those who are not cisgendered, male and female, etc., is going to be able to be disclosed and will be really useful in breaking down that overall population data.
And in fact, I'll just add there that Daryl's leading some work exactly about the experiences of the participants in our study who identified as gender diverse. And that work is really well advanced. So very, very interesting and great question.
Really good question. So we've got lots of really positive messages thanking you for your work, you two amazing creatures. And in fact, it's never too late to do this work, but I've had a few people in my ear going, why have we not done this before? And I think that's what happens, doesn't it, when you undertake a study like this? It gives you a bit of a baseline from which you can then move forward. So lots of lovely thanks in the chat. We have been asked if we can collect up the questions and send those out so that people can see the conversation. So we'll endeavour to do that in the pack, plus the links to your website, etc. Look, we are really hoping that we'll be able to work with Ben and Daryl next year when the research does come out to do a great big launch in Melbourne, as we did some years ago when we kick-started this piece of work with you. I just want to say thank you, along with my colleagues on the chat, for a fantastic hour. Really tough stuff, really hard to hear. But no doubt in hearing it, we might just be able to gear our systems and our services in a better way to be able to help people who in many ways have not had a voice. And this study's given them a voice. So now it's our job, once we get this research out there, to try and gear our services to be more effective and to advocate more, hey, Daryl, through the framework and a range of other activities. So have a good week, the rest of the week, everybody. Please thank Ben and Daryl for being here with us today and giving us such a powerful presentation, and look forward to bringing you more of this next year. Thanks, everybody. Lots of claps coming up.
Thank you. Thank you so much.
Thank you so much. Thank you.
Thanks, everybody.
Bye, everybody.